with this, I would like to welcome Dr. Amit to share the program update. Let me share the presentation.
Thanks, Ashutosh. And thank you, Dr. Professor, for joining us. And we are highly obliged for you to take out time and orient us on the program. I can just share our program. And we are about 2 years old into the program. And we started, the program is about secondary prevention of cervical cancer, early diagnosis, and then treatment through the new technologies, which you're already familiar around, TA and LEEP devices. And we started with the state of Madhya Pradesh as a demonstration pilot. And here we are highly grateful to ISCCP and Dr. Sarita for helping us to form the expert committee along with Dr. Kavita, and then the state of Madhya Pradesh Department of Health leading it along with Department of Maternal Health and Department of NCD. We also had participation of All India Institute of Medical Sciences in this. And along with them, we also had the ICMR, the National Institute of Cancer Prevention Research, as part of the technical groups. All these people help us to develop the training manuals, the treatment curriculums, and help us to get the project going. And they also helped us to set the master trainers rolling in the state of Madhya Pradesh. And over a period of time, I mean, we have been affected by COVID also. And last year, we had a big wave. This year, again, we had a big wave. And we want to learn from you how you really carried out the services. Dr. Partha was talking very highly of your program. For us, it has been a journey of learning and experience and development. So we did turn to hybrid training models where Causer, our lead there, in a sense, initiated that for cervical cancer through the training programs post-COVID-19. And we have set up about more than 200 screening sites for VIA. And there are about 776 HR trained even in these, I'll say, I mean, less than 12 months of the program rolled out on the ground in the state of Madhya Pradesh. VIA screenings have gained up to 33,000 in these 12 months, of course, which means that we had only 6 good months where screening were from 6,000 per month. In December, we got the devices registered in India. These are all new devices, and India requires registration before anybody can procure. And so now we are set for government procurements also for these new devices. And we started equipping the centers with TA and LEEP devices. So the trainings did also start in February and March, and about 19 facilities are currently equipped for treatment devices. Slowly and slowly, we are now, of course, taking the program also to the other states. And this is where the discussion is happening with the state of Sikkim, where we are also piloting a program around HPV screening with NICPR and supporting them for treatment through treatment devices through TA and LEEP devices. Then Causer is also helping us to take this program to the state of Punjab, where we are following the same kind of a model of developing the expert groups and then helping them to kind of deploy the TA and LEEP devices for secondary prevention. We'll also discuss the state of Tamil Nadu and Chhattisgarh on rolling out these programs, and we are just near the signing of the MOU with the state governments there. So that is on the program. Going ahead, we do want to learn from you in today's session. Ashutosh, can you move to the next slide? Thank you. In the sense of during the pandemic and during the epidemic, and Dr. Partha also shared, as I said, your example last week with us, in the sense of how the screening used, in fact, you increased the screening even during the pandemic times, and then the treatment of the screen positive women through the new technologies. So over to you, doctor, and we are looking forward to a nice and engaging section. Thank you.
Thank you, Dr. Amit. I now welcome Dr. Sarita to address the participants.
Good evening. Can you hear me?
Yes, ma'am, we can hear you.
Yeah, good evening and thanks to the carry on doing this. I remember Kausar and me talking about it at ISCCP conference in Vizag. That was April 2019. And then you all have developed the program and got it started in the state of Madhya Pradesh, and got the training and of the health personnel and the doctors and the screenings done. This pandemic has been a huge blow to the screening activity that has been started with so much enthusiasm. So I hope we'll be able to continue, and we seek guidance from Dr. Ashraf and also from the WHO on how to carry on this, because in view of the impending third wave of the pandemic also, and how to carry out treatment also of the screen positive is also going to be a challenge. So waiting to hear from you, Dr. Ashraf.
Thank you so much, Dr. Sarita, for your words and sharing your experience. I now welcome Dr. Kavita to address the participants. Ma'am, you are on mute.
Thank you, Ashutosh. A very good evening to all of you. Professor Ashrafunnessa, dear friend Sarita, Coster, and the team from CHAI and from our own health state ministry from Madhya Pradesh. Very good evening to all of you and dear participants. On this occasion, I would like to welcome Professor Ashrafunnessa on, being a master trainer and a technical expert for MP state, and being into teaching and learning for last 2 decades into preventive gynecology. I have heard you, Professor Ashrafunnessa, at various platforms in, AOJN, OCOI, and whenever you share your links, I have heard you doing a wonderful job in Bangladesh. And I would like to really, I'm looking forward to hear all your experience and to see how much we are little different from you, and what are the things which we would like to accept in our state, and good efforts of CHAI team for bringing Dr. Shankar Narayanan, then Dr. Batla, and then Partha, and now you. So this is something you never realize, drop by drop, you add on into the ocean. So knowledge is endless, and sharing experience is something wonderful, and I am a lifelong learner. So madam, over to you, and you are most welcome. And Sarita, a very good evening to you. IFCCP, we are looking forward to be there in your world conference. So thank you so much.
Yeah. I wish to also thank all the ICCP members who, very enthusiastically and without any hesitation participated in all the training programs, and they helped with training of the master trainers, of the healthcare workers, and it has really been very helpful for us.
Thank you so much, ma'am. Thank you so much, Dr. Kavita. I would like to emphasize once again our gratitude to Dr. Sarita, IACCP, and Dr. Kavita. They have been our go-to mentors, and probably we wouldn't have been at this point if it was not for their support and continued guidance. So thank you so much, ma'am, once again. I would like to now invite Dr. Ashrafunnessa for sharing her experience and her wisdom on how to carry forward this program in this difficult time when we are facing a mammoth task of not only screening, but at the same time, a very big challenge of not being able to mobilize them for their screening and for their management. So thank you so much, ma'am, once again for joining us and guiding us during this session. Ma'am, would you like me to share your presentation?
Yes, thank you. Good evening, everybody, and my warm thanks to Mr. Ashutosh Sharma and Dr. Shurita, President ISCCP, and also Professor Kavita, who are long friends of mine. And thank you for your kind words. And also thanks to Dr. Amit Bhanot, and also all the participants here who are listening to us. And also I'm thankful to Kausar Kidwal, who is keeping correspondence with me for a long time. Now, the experience in Bangladesh actually started since 2003. And basically, I belong to Bangabandhu Sheikh Mujib Medical University. And we always thought about screening program and prevention of cervical and breast cancer. Next slide, please. Yes. See, still the cervical cancer is the second most common cancer, and every year we get about 8,000 new cases. And next, we prevent those cancers. And our actually work started since 2003, when we arranged orientation meeting with all the stakeholders and policymakers, cytologists, histologists, gynecologists, radiotherapists, and we had to come to a consensus that we will do PIA method for cervical cancer screening, because the other methods were not feasible. Next slide. Yes. So, this is a very simple method with application of 5% acetic acid on the cervix. And if it is positive, they need follow-up evaluation by colposcopy, or you can treat them without evaluation also, that is a screen and treat. And now, most important beauty is that it is very inexpensive. And you can link the treatment and evaluation on the same date of screening, and very simple method. So we did a piloting in 16 districts, and mainly we started working with the government infrastructure in the district hospital, in the maternity hospital. And till 2010, the government expanded the program after completion of the piloting. So we have 64 districts. So all the 64 districts had center in district hospital or medical college hospital and maternity hospitals. And then after 2010, the scale up started to the sub-district level, we call it Upazila. And then we developed centers in the sub-district. About almost 300 sub-district has at the center at the moment. So altogether we have 464 center at all institute level, district hospital and maternity hospital, Upazila Health Complex. So it's, a huge expansion to most of the areas, even up to the grassroots level. And next please, next. Parallelly, we continued our colposcopy training at BSMMU and also different medical college hospitals. We continued training every year. We tried to develop colposcopy clinic in all medical college hospitals. So at the moment, we have set up in 33 medical college hospitals. 15 of them are well established, and rest of them are in developing or almost developed stage. So we are working on all these centers. We arranged basic colposcopy training, advanced colposcopy training. Also our master trainer visited Barshi. So we are very much grateful to Parthos, and we will never forget Saboni. And we also got a consultant from UK and other countries, so that we tried to establish the colposcopy clinic very strong, in a very strong way, so that patients get good evaluation and treatment facilities. Next. Now in 2010, we started Cnt Protocol. And before that, we used to take colposcopy, we used to do colposcopy and take biopsy, and we used to wait for the report. And many biopsy report, many women did not come back with the report. So the failure rate for treatment was very, very high. It's almost like 50%. So after actually the international team evaluated our program, and then WHO, UNFPA, and all stakeholders came to a consensus that we have to do the Cnt protocol, follow the Cnt protocol. Since then, we started treating without waiting for the histopathology report for all high-grade CIN. And also since 2018, we started treatment of all low-grade CIN, and also after seeing by colposcopy, because low-grade CIN, they also don't come back for follow-up. So due to that, we are doing all grade of, we are treating at the moment all grade of CIN following Cnt protocol. Next. Also, during 2010, we started using thermal ablation. That time, during that time, it was called cold coagulation. And Dr. Shankaranan, we are very grateful to him. He's always with us. And actually, they have given us 2 cold coagulator. And also, we arranged a workshop, and then we started the thermal ablation at BSMMU, and later on we started in Khulna Medical College, Rajshahi Medical College, and then government. At the moment, we are using almost 100 thermal ablation equipment, starting from primary, secondary, I mean from tertiary, secondary, and also in primary health center. Next. And one thing, thermal ablation is actually very simple equipment. Initially, we started cryo, but we could not manage with the gas supply. And thermal ablation is really cheap, handy. You can carry it. The health worker and nurses can use it, and they can carry it to the health camp, to the Upajala Health Complex. So Cnt became quite easy for us, because you cannot do LEEP in the LEEP is fine for the tertiary health care level and in some secondary healthcare level, but it is not possible at the primary healthcare levels. So for Cnt protocol, thermal ablation is really suitable equipment, because you just can use the ordinary electricity, and that is available even in most of our sub-district level. Now, also we started using gynocular. We actually did research for about 6 months with the gynocular with Karolinska Institute of Sweden. And we saw that is quite fine. I mean, the magnification is almost like traditional colposcope, and it's quite effective and for diagnosis, and it helps in treatment. So and you can carry it, it's pocket colposcope. So we started using it even at the sub-district level and during camp, so that we could continue our Cnt protocol more widely in different healthcare facilities. Next. Now, so almost half of the district of Bangladesh have colposcopy clinics, and we always used the IRC module, curriculum for the colposcopy training. And so far we trained more than 280 colposcopists there. Many of them are gynecologists, but we trained also medical officers and also trained some nurses, because it's very difficult to get a doctor in some peripheral districts, and senior staff nurses are very useful because they are doing VIA for a long time, so they can help a lot during colposcopy. Next. So I have mentioned that we actually don't practice skin and teeth. We do colposcopy or use colposcopy or gynecolar, then we treat by thermal ablation or LEEP. Thermal ablation cannot be used if you suspect really invasion or if the lesion cover more than 75% of the transformation zone. But you can use it in many cases, and you can refer the suspected invasive cancer and some Cnt to the medical college hospital, and you can use it in the Upajala Health Complex. And LEEP is widely used by the medical college hospitals. Next. So this is the data of Bangabandhu Sheikh Mujib Medical University Colposcopy Clinic. So far, we have diagnosed more than 1 lakh positive women and 30,000 women attended BSMMU colposcopy clinic, and rest attended other medical college hospitals. But failure of attending to the colposcopy clinic is always around 10%. So now we have seen that half of the BIA positive women had normal finding, and 34%, around 34% had CIN1, and 8% had CIN2 and 3, and almost 8 to 10% had cervical cancer. So 50% of the cases are actually, we see normal during the colposcopy. That's why we don't want to do over treatment. That's why we are using colposcopy. And actually colposcopy is very important because even if you see HPV positive, you cannot avoid colposcopy. So this practice should be, more widespread and among the gynecologists and in different centers as well. Next. Now treatment, we have treated more than almost 3,800. We have done almost 3,800 LEEP and 3,300 thermal ablation. And some women, they actually failure of treatment and follow-up is always around 10%. We could not practice much cryotherapy, but we referred many women due to cancer to the microinvasive cancer, also diagnosed quite a lot in the colposcopy clinic, and they all are referred to the oncology or gyne-oncology. Next. Now, in the meantime, we developed a National Center for Cervical and Breast Cancer Screening and Training at BSMMU, and from there we are helping the government for coordination and monitoring, because DGHS is not able to monitor so many women, and so we are helping them, and also we are keeping coordination with all the medical colleges, district hospital. Even we are keeping, we are continuing monitoring with the primary healthcare center as well. Next. Now, so far till 2013, actually, we are the data was completely paper-based, and even we used to collect, cumulative data from the paper-based reporting. So all collection of data and adding them, to develop a cumulative report was really a pain. And so many centers, you cannot collect monthly performance data. In the meantime, we observed that this district health information system, they are collecting data from the DGHS, from different primary, secondary, and tertiary level, by this database. And so we also thought that we can collect our cervical cancer monthly report. So we approached to DG office and the management information system, they agreed. And then since 2013, we started collecting monthly performing data through the DHIS2. It's simple, it's a simple database system developed by Norway, Oslo University. And until 2017, we depend, even for the individual women, data for individual women, we had to depend on the paper-based recording with the registry books. And but it is very difficult to follow this registry book to see whoever is positive, to get the telephone number and to follow them up. It's really very difficult. So then we observed that some customization of the data is happening in the DHIS2. So we also again approached the MIS division of DGHS, and we said that we want to do the individual data system for each woman. We want to keep the database. So then they customized and updated the VIR, CBA, MIS part. So since 2018, we started incorporating the individual data for each woman in the government database system. Next, please. So in the meantime, the government developed national strategy, and number one point was the vaccination of girls aged 9 to 13 years. We have already completed our piloting in 2017 and waiting to get the vaccine for so many years now, not yet getting it. But second point was the implementation and scale up of organized population-based cervical cancer screening program. That strategy was taken by the government. So for that, we had to emphasize more on the electronic database. Next slide. Also in the strategy, the government focused on that all skin positive women should be evaluated by colposcope or mini colposcope, and we have to treat them. All colposcopy suspected precancer should be treated by Cnt strategy. And also in the strategy, thermal ablation was just new equipment then, and even WHO did not recognize the equipment in that way. So we had to approach the government that we want to use it. So that is also kept in the strategy, that thermal ablation services should be organized at secondary, primary level, and all at the tertiary level, all services should be available, including the LEEP services. And also in the strategy, there is responsibility of monitoring and evaluation and quality assurance was given to the institute head and gynae consultant of all level, like primary, secondary, tertiary level. So they are responsible for the implementation. Sorry. Next slide. Now, then actually for the population-based screening program, we had to, give more importance on the electronic data tracking. So government provided us a dedicated server just for cervical and breast cancer screening. And that server is in the DGHS, and so the software was developed for individual data collection, and we use the NID for unique registration number. And in the database, the basic demographic data is there, results from the screening, colposcopy, and management, including histopathology, all are in the same database. And we developed a module with the help of DGHS for the training on electronic data tracking. Next. So this is the database where you can see the patient's individual name and all other information. And you can, and this database starts from the community. The community level, they do the basic database, and then the service center like Upazila Health Complex or medical college or district hospital, they can insert the screening report, and at the tertiary level, they can insert the colposcopy report and management part in the same database. And the national, with national ID, they can, the same patient can be seen from any colposcopy clinic, from any corner of the country. The data is available with the national ID number. Next. So we arranged a pilot program, and 200 Upazilas were selected for the pilot program, and 5,500 community clinics were selected. Community clinic is actually, one community clinic serves about 6,000 population. And we have seen that each community clinic has about 600 to 800 women who need screening. Actually, our screening target group is little different from the WHO, that is 30 to 60 years. So, and the community clinic, they have community health care provider, they have health assistant, and they have family welfare assistant. Actually, this health assistant and family welfare assistant, they are part of the Upazila health system and family welfare centers. And CACP is absolutely part of this community clinic. And so, but they, HA and FWA, they also come time to time and serve this population. Next. So we are training of the civil surgeons and Upazila health and family planning officers consultant, because they needed this training on population data, database and population-based screening, and also electronic database. So they needed to know how to do this, and they are the master trainer basically for this program. Next. Next. We also trained the senior staff nurses and data entry operator as master trainer. And later on, next slide. And all these master trainers, they arranged the actual training of the field level worker. In each Upazila, they trained all the community clinic, community healthcare provider, health assistant, and FWA, 30 from each, 3 from each community clinic and 30 together. They trained all together. They are training, still the training continuing, and 16,500 health workers will be trained at the end of this project. So they are trained on counseling, on referring, on registration, and these are the things for the field workers. Next. So this is the registration referral system. During the home visit, the health assistant and FWA, they do counseling and they fill registration form. And they give one part of the form to the woman for visiting the Upazila Health Complex for screening, and another part goes to the community clinic, CACP, and CACP does the e-registration and generate the unique ID. And at the Upazila Health Complex, the SSN or doctor, they do the screening, VINCB examination, apart from counseling and other things. And positive patients, then they will go to the medical college hospital, district hospital. Some of those Upazila, they have also the treatment services. Next. Now, just we are working in this area, and then the COVID-19 pandemic started. So we are stuck. And from end of March and April and May, everything, are stopped. So actually, like other programs, it's just like a standstill condition. Next. Then from beginning of the June, government said that you can start the routine activities, and then we initiated the screening program again. We tried to activate it. Next. So we followed everything. We followed the triage area thing and the telemedicine and many healthcare facilities. They started elective procedure, elective screening, but it was really difficult because of the COVID pandemic. We really failed to reopen initially. There's many screening centers. Next. Now, as you know, that we tried to limit the visitors and then avoid crowding and also mask. We tried to ensure the hand washing. We introduced it. Next. Next. Now, what we saw, at the Upazila level, it was really difficult. Many of the Upazila, they could not start the screening, and we saw that instead of 20 to 30,000 screening every month, we got in the Upazila only 1,000 screening. So in July, we monitored it by DHIS2. Next. The district level also, we saw that screening was about 1,300 only. And next. So it's really very painful that they could not start the screening. We started monitoring with help of DGHS and with joint meeting with the MIS, and also we took ministry in the meeting, and we phoned them. We did many Zoom meetings with the civil surgeons, with the EHFPO and the health authorities, but still it was very difficult to activate. Mostly the next slide. Colposcopy clinics, they are most affected because medical college had high burden of COVID patients. So no positive patient was getting, treatment or evaluation. Some patients, they were, traveling long way and coming to BSMMU because they are not getting the services in the medical college hospitals. Next. So actually, each healthcare facility, they have a different situation was there. And, government divided the areas in red, orange, and green zone. So we started working in the green zone, and we're approaching to the Upazila healthcare facility that whether they can start. And they were trying to, but patients really, they did not want to visit Upazila Health Complex because as the COVID test facility is mainly done from the Upazila Health Complex, they said all the fever patients are there. So they were not interested to visit the Upazila Health Complex. So this was continuing for a long time. Next. Anyway, we would try to telemedicine and even add and local cable line, but nothing was working. But we started screening without appointment or whatever, and opportunistic screening we were encouraging. Next. But some of the district hospital and Upazila Health Complex, they started counseling of women that COVID-19 virus is not, has no relation with the VIA test. And gradually it improved. Then suddenly we discovered that that during the registration, we have done a registration of lots of women in the community level. At the community clinic, the health worker, they have registered about 4 lakh women who did not have a screening and who are just waiting to visit to the Upazila Health Complex, but not visiting the Upazila Health Complex due to COVID situation. Next. So then we took a different strategy that we had to make some changes in the program, and then the nurses from the Upazila Health Complexes, they started visiting the community clinic and starting screening there. And then then BSMMU also helped them by providing gynocular and also the thermal ablation equipment. So they started screening at the community level, and that improved the situation gradually. And later on, with when the pandemic is settled little more, then we started, parallelly, we always encouraged starting the program at the Upazila Health Complex. District hospitals recovered more, and medical colleges also recovering very slowly with the performance of the colposcopy clinic. Only last 4 months, we were monitoring everything by the DHS. We did monitoring almost every alternate month, that which center is performing how much. So this is really benefits looking at the cumulative data from BSMMU or from DGHS, that it's very easy to see, monitor the each individual, individual centers. So whenever we are seeing that this center is not performing, we used to arrange even Zoom meeting with them. So in this way we are working. And next slide. So actually, so community clinic, the women, they don't get scared to come to the community clinic, and they started going to the Upazila Health Complex also. But now again, this second wave came, and situation is just like the April last year, and now all the Upazila Health Complex are gradually, they are really not working at the moment. So we are again going back to the community clinics to work more in the community clinic. So this is really a different strategy, and I don't know whether we will recover from this situation. I don't know how long it will take, for this recovery. Next. So treatment by thermal ablation is really very useful during this COVID pandemic situation. It's just apply 100 degrees centigrade temperature, you heat the probe and apply, and it does not need any anesthesia or gas. That is the most important thing. Next. And nurses can do it, and sterilization of the equipment is very easy. Now LEEP, actually LEEP is quite safe in COVID pandemic, but thermal ablation is more safe because it does not cause any fume. LEEP is safe because, also safe because it does not, if you use the smoke extractor, the smoke will not be, escaped from in the environment. And also that genital tract fluid does not contain any COVID virus particles. So otherwise it is safe. At BSMMU and some of the medical colleges we are practicing a LEEP as before whenever is necessary. Next. So you see, we by the electronic database, we could monitor, we could compare the performance. Actually Dhaka division and Chittagong division was more affected by the COVID-19, and recovery was really difficult. Still we monitored and we have tried. Next. And so even in this pandemic, we could reach to 4 lakh screening, 4 lakh women we screened in last year. So at least, I mean, we had a plan to increase more, but we could not due to COVID situation. So at the moment, we have screened altogether almost 3 million women, though we have to screen 22 million women. So it's a long way to go. And up to positive women are more 1,19,000 women are PIA positive. Next. So actually this electronic database system helped us a lot for monitoring the whole country. All these 464 centers we monitored every alternate month extensively. And without monitoring, actually, you will not understand that what is happening. You cannot phone all the centers and you cannot accumulate the data, all the centers manually. So this is very useful, this database. But we need mass awareness creation, also electronic monitoring. Apart from electronic monitoring, the recruitment of proper staff is important in the field level. If you work more in the field level, you need more experience, staff. You have to train them repeatedly, and IT equipment is also important. And good internet connectivity is a problem. We are still facing problem with this, less availability of the equipment or internet connectivity. But with improvement of all these things, I think we have to work, because I don't know how long this COVID will, when COVID will go, when we can finish our vaccination, and when we can get rid of the COVID situation and we can go back to the normal life. So even after that, for population-based screening, electronic database is very important. So basically, we used this electronic database system before initiation of the COVID, but we used this database so much during the COVID pandemic situation, and we are still continuing it. Thank you very much for your patient sharing.
Such a beautiful presentation. Such a learning experience. Yes, yes. Should I say something?
Sure, ma'am.
Yeah. So thanks a lot, Professor Ashrafunnessa, because it is so inspiring and so motivating, your experience of like working not only during pandemic, even pre-pandemic. So what I would like to say, because here the CHA is here, NHM is here, medical education is here. I've been talking on the subject, and I've been sharing this with CACer at times, that we have to work on infrastructure, database, and we need people to help us in analyzing the situation. The way Professor Ashrafunnessa said, there is a need to strengthen our data analysis and data capturing, because CACer is there or not, I don't know. She is there? I don't know.
Yes, she is there.
She's there. Okay, fine. Yeah. So one more thing on this platform, I would like to say that if you really give me 2 trained people or 2 motivated people at Jabalpur, I will open my all record rooms for you. Because when I was looking at the data from Bangladesh, even in Madhya Pradesh, we have done more than, मुझे लगता है 1.5 lakh से ज़्यादा we have done screening in these many years. But the only thing is that it is all in hard copies. It is all in registers. If you could, get someone to help us, maybe you will get enough data to compare pre-pandemic or your initiative 2018-19, and maybe we can move ahead. So very inspiring and motivating, Professor Ashrafunnessa. And if participants have any questions, I think it is time for them to interact and ask questions. Thank you so much.
Thank you, ma'am, and thank you so much, Dr. Ashrafunnessa, for sharing your experience so far. And moving ahead, we will take the questions from the participants and some general questions that we had collected from our service providers and master trainers in the program district. So first, we have a few questions in the chat box from Dr. Sarita. The first question from Dr. Sarita is, what was the ASR when screening was started in 2005 till now? Dr. Ashrafa?
Sorry, I did not hear the question.
Ma'am, can you see it on the screen also? What was the ASR when screening was started in 2005 till now?
Oh, right. I think in 2005 till now, I cannot remember the data in 2005, but probably during that time, it was about 25%. I don't remember.
Oh, okay.
And what is it like just before the pandemic?
Protocol, no. Or no biopsy involved. No, we are doing biopsy for high-grade lesions.
Ma'am, Dr. Sarita, I believe, had a follow-up question on the first part.
Yeah, so I wanted to know, Dr. Ashraf, what was the ASR when you started this program? And just before the pandemic, if you have any statistics?
Before the pandemic,
what was the ASR? The A standardized ratio and as well as of cervical cancer.
Yeah, I think that IR data only we have. We don't have our own data.
Okay. Right.
Our own data so far. Maybe after 2 or 3 years, when we accumulate the electronic data, then we can give the.
Yeah, and also, you know, the biopsy, so your treatment is being done without biopsy.
Without biopsy. We do colposcopy and we treat, but in case of CIN2, 3 or suspected invasive, you know, we take biopsy, but we also treat them, not in suspected invasive, but for CIN1, we don't take biopsy, we treat them. For CIN2 and 3, we take biopsy and treat them. Then we compare the biopsy report. And if we see invasive, then we call them back.
Yeah. Okay. So now you're, since the treatment is being done by the nurses. So number one is the nurses qualified, I mean, licensed to do the treatment? Because that is something in the Indian government, they are not allowed to do the treatment. And secondly, do they take the biopsy for high-grade lesions, and are they licensed to do the procedure?
That is actually in the strategy, nurses are allowed. That's why in the strategy it is mentioned that they are allowed to take biopsy.
They are okay. They are allowed to take the biopsy also. Okay, so I think this actually this protocol will need to be changed if in our country the guidelines will need to be modified.
Yeah.
If we have to actually go down to the right to the periphery.
I know that India does not allow nurses to do the colposcopy, but in Bangladesh our government is allowing. Yeah, that is the difference, I think.
Yes. So I think if this change, with the change, then definitely they can be, they can be trained and
in many European countries, the nurses do the biopsy, the nurses do the LEEP. So why not in India? Because you will not get so many trained doctors in the peripheral area.
Exactly. Yes. So this is, I think, this as a policy, this needs to be changed. Yeah. Yes.
It's a policy making issue.
And what was
yes?
And what was the duration of the training for colposcopy? That
colposcopy, the basic training is for 10 days.
Right.
And as advanced training is for 6 days. But they see lots of positive patient, you know, and they practice LEEP during the training.
So for nurses also, it was for 10 days, the colposcopy training?
Yeah, 10 days, but nurses are not allowed. The nurses are allowed only to the thermal ablation, not the LEEP.
Yes, of course.
And they are in the strategy, I mean, they are most of the time they are under supervision of doctor. But in some camp setting, you know, when a camp happens in Upazila Health Complex, one spot is in the Upazila Health Complex and 3 spots are in the community clinic. If any difficult case happen, you know, then the doctor can see the patient. So for 4 points, one doctor is supervising.
Okay, so there is a doctor for every. Yeah. So now during the pandemic, the nurses are doing the screening and the treatment. That's what I understand. Yeah. Okay. So are the patients having are they having a rapid antigen test or something for COVID before they are having the treatment, or are you doing it are they having it without that?
No.
No. Okay.
The thing is that actually they always take the temperature and they don't allow any patient with fever. But no, I mean during screening, we don't allow any patient with the fever, with history of fever. That is the thing.
Okay.
And we always use the area for a screening, you know, which is at the moment the full lands, their lockdown, completely lockdown is there. So those areas, everything is stopped. But in the green area, everything is continuing, screening is continuing. And in our hospital, what happens in the hospital, that even in the hospital, we don't allow patient with fever. So that's why if there is any patient comes with fever, we send them for COVID test and we tell them not to come within next 1 month.
But they could be asymptomatic positive as
well. But for screening actually, it is very difficult. If you want to do COVID test, they will not come back again.
Yeah, but what about the treatment? Before the treatment, are they having the COVID testing or at least the rapid antigen?
No, we are doing COVID testing only for admitted patient, like, you know, any patient who is admitted. You know, all these cases are actually LEEP and thermal ablation. They are day cases. We're not, we're not doing tests for them. But in case like one patient was admitted last month for LEEP, and we did all the tests because she's being admitted and she will go to the OT, and so she had COVID test before admission and even during during the
another question, Dr. Ashraf, is how is the acceptance? If you talk about treatment without biopsy, there's a lot of resistance from the gynecologist, basically, the gynecologist community.
I agree with that. But when you see in the data that 50% failure of treatment rate, if you want to take biopsy and they will not come back with the biopsy report, so that's why it is now accepted that without the biopsy report, there is some degree of over-treatment, but with failure, there is some cancer cases actually really come back. After several years, they come back, with cancer.
I know, I agree, yes.
Yeah, we have seen many cases actually from cases.
Yeah. Yes, thank you so much, Dr. Ashraf. That was very enlightening and very useful to learn from your experience.
Thank you.
Yes.
Ma'am, next question we have from one of our team member. Question number 6 is screening and treatment guidelines, screening, colposcopy and treatment uniform across Bangladesh, or there are some facilities that also do screen and treat, or screen, biopsy and treat?
Actually, many other countries are also, we do Cnt screening. All right, this is Cnt. Yeah, other countries are also, even in India, some studies are on Cnt. So Cnt is practiced actually by several countries now.
Right. Thank you, ma'am. And the last question we have.
The Cnt is recommended for many, there is, in fact, there's a meta-analysis on see and treat. If you see, it appears to be, this is after colposcopy. Screen and treat still, it's not being, although WHO has done many studies, but still, not many countries are, actually the low-income countries are following this screen and treat. Although there are pilot studies which have found to be very effective, but I think it's Indonesia is the only country where they are carrying out the screen and treat without colposcopy.
Yeah, in part of the Thailand also they are doing screen and treat.
Yes, yeah, yes.
We are in MP. We are see and treat. We are still do VIA positive, cytopositive, do colposcopy, and it is a routine practice if the score is more than 2. So then we go ahead with the biopsy. It's like,
yeah, but Dr. Kavita, if VIA is positive, why are you doing a pap smear again? Because that's another screening.
No. We do see ours is a Sarita Teaching Institute, and being in the teaching institute, we teach students the way we used to teach our toddlers like अनार का आम का, ऐसे ही हम इनको speculum डालना और PAPS and VIA दोनों होता है. Means first they will take cytology and then they will do VIA. So the chances of missing a disease is minimum because the sensitivity and specificity of PAPS and VIA are different. So being in teaching institute, otherwise if you're practicing outside, then the strategies are different. But ये पाठशाला है, तो पाठशाला में तो उनको सिखाना तो आज सही है, फिर इसके बाद
I agree with you. And also at BSMMU, now whenever we cannot see the scomocolonal junction, we do liquid-based cytology. And for CI 1, 2, 3, all we do biopsy at the institute level. But when you are in the Upojila level, sub-district level or community clinic, then you cannot take so many biopsy. So we can take biopsy for high-grade lesion then, not the low-grade one.
Even we are in a medical college, and we then decide, the premenopausal we do VI, and the peri and postmenopausal we take a pap smear. Because we know that, with the pap smear, although we take it, many patients don't come back even to take the report actually. So that is what your effort, the whole effort is wasted, taking the pap smear, sending it to the pathologist. So much effort is going, and that the patient never, if the patient doesn't come back to take the report, then we then don't know what the report is. So we do a VIA for the premenopausal, definitely, and the postmenopausal, we take a pap smear.
Yeah.
We do both. Because, when we take cytology, this pathology MD students, they get opportunity to learn on cytology. So this we have discussed with the head of pathology, and it is in the mutual agreement that we should not miss a patient, and we should teach our student as a strict teacher so that they don't miss anything.
Yeah.
But definitely, Professor Ashrafunnessa, your this data analysis, data keeping, this is all this is something missing here. And I hope the NHM people, CHAI people, medical education people, they will help us out, because I could see
you can use also DHIS too, because WHO recommended use of DHO for cervical cancer screening. And it is available. Any country can use it.
Yeah. And in one of your slide, I could appreciate that in medical college, you have shown 0 colposcopy or 2 colposcopy, whereas at your center, it was 100 plus. So that, gives an indication that there is a need to, develop a preventive gynec oncology within, independent.
And we did about 2000 in 2019 we did almost more than 3,000 colposcopy new cases, and this year 2020 we did about 2,000. So actually the patient from different districts, they just came to have the colposcopy. They said this actually is very difficult during the pandemic. All the gynecologists are working for C-section, and then they cannot do any routine work. So very difficult. Again, the same condition is started, in Bangladesh. All the colposcopic clinics are shutting down.
But you had too many patients, Professor Ashrafunnessa, because a year due to lockdown, we had only emergencies, obstetric emergencies. People they didn't come out from their home as a result of lockdown and transport problems. So wonderful learning from you, interaction, a very good interaction. And Sarita, it is good for we people sitting when we interact with for policy making, and you taking a lead as an IFCCP and now doing world conference. I think you should take up all these issues, because after all we have too much of data, but the only thing is that it has to be organized, and we Indians can show that.
It's very difficult to handle the paper-based data. Really, it's very difficult to convert.
I think in MP, Tata Trust is helping you all with the data management, right?
I think CaCx can tell. I have no idea. And NHM people can tell.
Yes, that's what I understand. The Tata Trust is helping in the patient tracking and data management.
Yes, absolutely, Dr. Sarita and Dr. Kavita. It's Tata Trust, and we have Tata Trust representation also. And I would request Abhijit or Rehan. Rehan, you've typed a question in the chat box. Would you want to ask Dr. Ashrafunnessa yourself?
Good evening, ma'am.
Yeah, which one?
Rehan, you need to just switch on your camera so that we can also, we have a picture along with the name. Great. Thank you. Thank you, Rehan.
Ma'am, good evening, ma'am. This is Dr. Rehan from Tata Trust, Madhya Pradesh. We are helping the state to start using this portal, this Ncd application for screening and management of Ncds, and this including 3 common cancers like oral cancer, breast cancer, and cervical cancer. So we had a portal at from the periphery level till tertiary level. At the periphery, ANMs are responsible to do the initial screening. Then the positive or suspected cases are referred to PSCs for examination and further diagnosis. And then the cases will be taken to DH and higher institutions for further diagnosis and treatment of those cases. So all these cases have been entered through application, tablet-based application, starting from the ANM. Then the medical officer at PSC level have to update the examination part of that case, and the diagnosis and the treatment part, the test he has ordered. He has to enter the detail of the test in the portal, so that the real-time clinical information can be accessed at the DH level or at CSC level, even though the medical college are not thought to in this for this portal. We can take, if Dr. Kavita is interested, we can take medical college as well for this in this application also. So the question is, I'm asking at facility level, what any challenges you are facing in entering the cases in the software application which is being used in Bangladesh, as we had heard in your presentation that all the database is in software application. So what is the challenges you had faced in data entry of clinical information in the portal?
Yeah, actually, I think you are also using almost a similar database. That are you using any unique ID number for the database?
Yes, yes,
what is that unique ID number?
It's a system-generated unique ID, which is almost 10 to 12 digit long.
Yeah, that's right. Actually, what problem we are facing that is from in the community level, the community care health provider, they are trained for the data entry, and they are given the equipment also like tabs. But sometimes it does not work well, and sometimes they don't get the proper internet connection. So that is one problem. It happens in about 10% of the cases. Then again, we try to solve it, or we complain the MIS system, then they try to solve it. So that is basically, not the software problem, that is the hardware problem. Yeah. And again, another problem is that DHIS2 sometimes they update the system, and during that time they, keep everything closed for 3 to 4 days. And during that time, nobody can do any data entry starting from community clinic to medical college hospitals. So that is another problem we face. But, still, we have to give time to DHIS2 because the data updating also needed. So that is one problem we face. And another problem we face, that monitoring is a problem, because data monitoring, DGHS is responsible. The MIS section of DGHS is responsible for data monitoring, but they don't have adequate manpower. So what we do, we monitor, we just completed this 2020 data, counting, calculation only last month, because during the pandemic, many centers, they did not do any data entry. So by checking the data, we have to find out who is not entering the data. Then we have to phone that responsible person, because he or she has the code only. Even the SSN keep us by phone that, oh, we have done so many, why it is not entered. But you have to find out the statistician who has the code number, and he will do the data entry. So these things actually, for monitoring, you need some people, dedicated people. They have to check whether everybody is doing data entry properly, whether they are doing, there is column for positive and negative. And if somebody does instead of negative, they do it vice versa. So you have to edit little bit, and this monitoring is important. This is tedious job. But if you can do the monitoring, then this is fantastic. So actually DGHS is depending more on for screening data on us, because they don't have manpower, but they have to develop a system for tracking every data, particularly NCDC data. You are doing very good thing, because you are doing all this data in the same system, isn't it? Our government should do that also, but they can do it. This is the same system. This system is DGHS system. So just this same database, actually, the database we are developing will be used by NCDC one day, because we are doing the basic data there. The same data will be used by other diseases. One thing, like, in maternal health, they are also using DHIS2 for data keeping, but they are not using national ID card number for unique registration. So they are doing data duplication. But in cervical cancer screening data, there is no data duplication, because everybody has only one ID number. So there is no chance of duplication.
Yeah, I think Dr. Rehan, you should also extend it to the other states and develop it in the sense that now, if we do enable entry for at every, entry of data, like somehow, get the patient also to enter their own data. Is that is possible? That will be really useful, because what happens is the data may not be entered into the system, but the patient may have collected her report. So, so if they can actually just upload that picture of the report, then that will also be helpful in tracking the data. So they should have something.
We can take, yeah.
Yeah. I think the vaccine app and, the COVID actually has taught us a lot in terms of how we can organize things. So the COVID app, you should develop something like that app for cervical cancer or all common cancers, so that patients will get information also, and they can even they can track their reports, and they can track the health facilities.
Just to answer you, this software is pan India. It is implemented in all state, on all UTs in India. And secondly, and the MO is capable to print the prescription. And for the beneficiaries, for the patients, we are in process to develop auto-generate message just to remind the pending screening, the pending follow-ups. Yeah, it is in the pipeline.
Okay. Yeah, that's good. That's good to know.
I would like to thank Tara Trust for the support that they have extended towards the digitization of records. And we are working very closely with them so that all of these screenings, which are now in registers, can now be digitized. A lot of screenings have already been digitized in the MO portal, and really looking forward to medical colleges now being a part of the facility base in this platform also. So thank you very much, Abhijit. Thank you very much, Rehan. And thank you very much for taking out the time and being a part of this conversation. So Dr. Kavita, I think we are very close to the digitization dream that you've always envisioned.
Yeah.
In the interest of time, over to you, Ashutosh.
Thank you. Thank you, Doctor. Ma'am, taking on just last question, one of the data points that you shared during your presentation is in the colposcopy that was done for around 30,000 women, 50% women were found to be with normal findings. First question is, can we call these cases as false positive cases identified at the periphery? Second question would be, what has been the strategy so far to reduce the incidences of such false positive cases being reported from the lower level of facility?
Yeah, actually these PIA positive cases, those are actually can be considered as false positive if you think, if you compare with the colposcopy findings. And training and refresher training, is important. And we took the step, to reduce the false positive by training and refresher training. Problem is that these nurses are transferred so frequently that, nurses after training, they continue this false positive for about one year at least. And the nurses who are 2 or 3 years, who have 2 or 3 years experience, they do less false positive. We have seen that. But every year we are losing lots of experienced nurse. They are, transferred to other program. So we are trying to prevent that transfer. We are talking to the ministry, we are talking to the Directorate of Nursing, but nothing is working, particularly in this COVID situation. They take lots of trained nurses to manage COVID patients. And that time is really very difficult. So it's the experience of nurses very important.
So Dr. Ashraf, any plans of introducing HPV testing, because that's more objective?
Actually, it depends. We discussed it with the government, but the main thing is that the price of HPV test is, factor, and also which test are you going to use? Can you give me some idea also? I asked this question to Partho, to Shankar so many times, nobody can answer which test to use and the cost, how to reduce the cost.
Yeah, but since they say it's a once in 10 years testing.
Yeah,
so
but
in terms of
what is your plan? I also need to know that. What are you thinking?
I'm just asking you. We have to approach the government. Well, the policy has to be, it has to be decided by the government. But in terms of, I think what they say is even COVID testing also was expensive to begin with. But then gradually the government put a cap on that. And it has now, the cost has come down. So that way, once it's implemented, the cost will eventually come down. Also in terms of the number of people needed, personnel needed for doing the screening, in terms of the number of colposcopies also will be less if you start going for HPV testing. If you're only going to colposcope the HPV 16 and 18, so the numbers should come down. That's what the literature and the data says.
Yeah,
I think eventually, yeah.
But a cost of test is a barrier to the government. You cannot approach government with a cost, the test will cost at least 2,500 in Bangladeshi taka. What, I don't know how much cost in your country.
It depends. Here it's very variable depending on the lab also.
What is the lowest cost?
the lowest cost is one that is given by the Lal staff, that is 500 rupees.
And you will approach to the government. We are trying to approach also, see what they, difficult. National level, if you do 22 million HPV tests, that will be huge cost. And your cost will be even more. If it is just $1 or $2 or $3 test, that is different.
Yes, I think collectively, if we all countries pressurize them, they should reduce the cost for the low-income countries. We should pressurize the companies.
Companies are all in India. Bangladesh does not
have not in
company.
India.
So I cannot press.
They are not in India actually.
Actually,
if an Indian company
makes them, then
reagent
you want to buy, the main person is in India. That is a problem. So you reduce the cost first. Then we'll try.
Yes, we will try.
Thank you, ma'am. Thank you so much.
Thank you.
I would like to thank everyone for their attentive listening and their active participation throughout this session. Before we close this session, I would like to invite Nitin sir to extend vote of thanks on behalf of ChAI for our esteemed guests and participants. Sir.
Thank you, Ashutosh. Thank you so much, Professor Ashrafunnessa ma'am. On behalf of ChAI MP team and also the ChAI Cancer team, which is being represented by Dr. Amit from Delhi. We're very, very thankful to you for taking out time. It is a little more than the stipulated time, and you have been very actively participating. Very, very thankful to you for that. Your experiences that you've shared are very insightful and very relevant to what we do. And it will definitely help us modify our strategy as well because of the similar demographics. So thank you so much. And also the lessons that you shared regarding working through pandemic, again, very relevant to us. We are also very thankful to Dr. Sarita and Dr. Kavita ma'am. You've always been pillars of support, and your interactions, of course, definitely helped us gain a lot of knowledge even now. Thank you so much. We are also thankful to the Department of Health for supporting ChAI all the time, and also the MH and NCD divisions of the Department of Health. We have also got excellent support from the Department of Medical Education and AIMS Bhopal. I'm also very thankful to Tata Trust and Wish Foundation for their continuous engagement and partnership. So thank you so much, and thank you for taking out time today.
Thank you, sir.
Thank you.
And
thank you
everyone.
all. Thank you.
Thank you.
Before we close, I would request everyone to switch on their cameras, please, so that we can take a group photograph.
Problem with the light in this room. Can you see me? Actually, I cannot see myself.
Yes,
oh God.
I think
I know
just hang on a minute. The light, I think light has gone. Just
it's raining heavily here, and there is the internet, the Wi-Fi here is gone. I'm just logged in through my phone.
got it.
Thank you. Yes, thank you, everyone. Thank you for joining us and for contributing your valuable time for the session. This definitely has been an enriching session.
Thank you. Bye-bye. Bye-bye.
Thank you.
Thank you.
Thank you. Thank you. Bye-bye.
See you.